Thank you very much, Bob. It's really a pleasure to participate in this. And way I've approached this topic is to really give you an evolutionary story of the indications as they've evolved in the use of this field, which is really over about a 25-year period has grown rather dramatically. And in so doing, give you the devices as they evolve that help support the expansion of the application of this technology. This is somewhat of a chronology and a listing of all the different indications where we began with post-cardiotomy, evolved to bridge, evolved to this term, which we'll define as those who are not considered transplant candidates, therefore an end destination therapy, typically for age or things like recent cancer, and different categories as bridge to candidacy. Getting to these, Dr. Yaqub will talk a bit about recovery. I won't spend a lot of time, but now this evolution into less severe heart failure and partial support. So the initial, as I said, was for a failed cardiac operation, unanticipated for a variety of reasons, and largely they were able to support either the right or left. This is almost a form of cardiopulmonary bypass that you could support the circulation very effectively. This is usually done in terms of hours at the most, days. Hopefully looking for cardiac recovery, and that was the simplest application of this. It could be done on the venous circulation with an oxygenator in place so that you could really essentially have cardiopulmonary bypass out of the operating room and support these patients relatively effectively with retrograde perfusion of the arterial circulation. And again, this was very simplistic, and patients looked a lot like this, and if you were thinking about going to transplantation or other advanced therapies, you can see the technology by today's standards looks quite cumbersome for supporting someone with shock or very advanced stage cardiac dysfunction. So as we evolved to newer and more effective devices, we could consider going to bridge to transplant. Those early devices, as I said, it was almost a rush to find any donor, and because they felt that these people had so many comorbid events, they were always on anticoagulation, and it really made quite a challenge. But with the introduction of this device, was really the first pulsatile device to support the circulation, an elective proposition. Two Bjork-Shiley valves here allowing blood to be drawn in a vacuum into a velour-lined sac that had an actuator plug that as it filled, it would displace electrical signal that then caused a pneumatic compression of this and pulsatile ejection out into the systemic circulation. You might understand from this portrayal that this literally was extracorporeal and sat outside the body with devices like this, the draw and the return line open on the chest. It seems rather simplistic, but this was, as far as we know, the first patient to actually get out of bed, be extubated, and then move to exercise, and he has biventricular devices in place. And one of the most important parts of this picture is to look at the refrigerator that was the pneumatic supply. Professor Smiley, this is literally what we had in the concepts of going home or being ambulatory. This is about 20 to 25 years ago, but this device really brought the field forward in terms of having people that could be supported for now weeks and months and allow them to recover and regain function and do quite well. We saw a number of patients who were considered within the realm of advanced therapy, but for whom the cutoff of transplant age at that time was about 60 to 65. And so the development of this concept, so-called destination therapy, came forward, and that really was moved rather dramatically with the next iteration in left ventricular assist devices, and that was now an implantable system that went from pneumatic to electrical power. And I'm sorry these videos don't show, but you can see cannulating the LV apex now and having blood passively being drawn into a reservoir that again has this pneumatic displacement pump like a bellows that ejected the blood back out in the circulation. So this was impressive because it could follow atrial fibrillation, and there have been patients supported with VT in excess of 200 a minute, just allowing the heart to become a passive conduit and displacing this in a pulsatile manner. This also, as I suggested, went away from the refrigerator-sized pneumatic drive to now electrical power sources where the batteries could be worn in this configuration, and provided a tremendous step forward in mobility, and the indication for destination therapy came forward in that the first trial of those devices was actually called Rematch, portrayed here in red as survival of those patients who had LVAD support versus the terrible survival of the medically controlled group. And I think you can see that while statistically significant, we had trouble with device durability, that about 50% of the devices had to be replaced within 18 months because of device failure. That really brought the technology forward when the engineers decided that if we wanted to miniaturize this, we had to get rid of pulsatile flow and move to continuous flow. That was quite a step forward in evolution, and they did this with cattle that had devices implanted from the time of birth, and saw normal organ function and development in the animal. We presume that they had normal cognitive function as well, but we moved from those preclinical studies into the placement of this rather astonishing change in the technology. This is the HeartMate 1, the previous pulsatile device, now to 1/5 the size, 1/7 the weight of this small continuous flow pump. This pump also has a single moving part, which is the rotor, which draws blood on a continuous basis and propels it back into circulation in a non-pulsatile manner. This, I think, really gives you a fairly good sense of, here's the arterial pressure tracing as the device is being initiated, and the speed, which is directly correlated with the amount of draw and blood removed from the LV apex. And you can see that the arterial pulsatility goes down and down until you're at full speed, in which there really is no pulsatility at all. It was a rather bewildering phenomenon to have a patient walk in the office and be talking with you, but to reach down and find no pulse and listen, and you can find no heart tones. These people were doing obviously very, very well. But this technology really revolutionized the field, and we began to see this kind of survival free, and this yellow line is the initial report, and then as we awaited FDA approval, had continuous access. And you see this these are people that were in cardiogenic shock and an end-stage heart failure, and to see them functionally alive and doing well at this interval was really an astonishing change in the field. We saw it applied for destination therapy as well, and began to see probably about a 10% difference in overall survival. But when we went head-to-head of the original pulsatile flow versus the continuous flow, this data made it very clear, and within a year and a half of this publication, the production of this device, which had been the centerpiece, was basically abandoned. We moved from still a pocket requirement for the original iteration of the continuous flow pump now to a completely contained within the mediastinum and within the pericardium. And this apical implant, you can see the motor and rotor now requires no pocket, and really revolutionized the field even further. And I think you begin to see how much miniaturization these pumps have, and change from a centrifugal to an axial flow and magnetic levitation, so the blood contact and trauma to the blood was reduced rather dramatically. We began to see this kind of even more astounding when you look at this outcome at 180 days of 94% survival. This technology has stood the test of time, and one of the most important advances of this technology is the durability. These devices are now speculated to have no device failure for periods of 20 years, and so we've taken that out of the equation, and the need for replacing these and the morbidity and so forth associated with it really brought forward this technology into further application. One of the interesting observations as we got into this is, where was the age break? And this was a relatively small series from San Diego, but impressively showed that if you look at the outcome and adverse effects as well as survival, the population over 70, which contained, I think, 8 people over the age of 80, but who were incredibly functional, and showed that this technology was really more about physiologic age and really imposed no significant barrier. I think this slide tries to describe where we've been in this technology and the evolution from that first trial that I reported to you, the rematch trial, now only about 11 or 12 years ago, to where we are at this juncture with reporting things where we are in the realm of 94% 6-month survival. So this improvement in technology has allowed this rather substantial expansion, both in numbers and in the indications for these procedures. But there have been tremendous ongoing, and these devices I'll show you now are in clinical trial. And I think it's hard to appreciate just how much miniaturization. This is a pin-light battery size on both devices that will allow it to be more simply applied to both the right and left circulation in one installation with long-term propulsion. Another smaller and smaller iteration, this is the new LVAD. It's about to go into clinical trial. I think you get a sense of just how small these devices. It certainly is applied into women without any limitation and now into children. And I think this technology is going to revolutionize the field. This is the third form of the device that's still in clinical trial. But I think one of the biggest advances that's probably going to be coming forward in the next year or two is to completely eliminate the drive line. All of these devices with electrical power have to be connected to a power source, and so that requires a transcutaneous battery electrical cord. And with the elimination of that and completely internalized, these devices, I think, will have removed the last barrier to being a superior alternative for advanced therapy. The concept, we saw a lot of people, and we saw a lot of people in critical shock, and you didn't know them. They came without any understanding of their past history, complications, and so forth. And so before you implanted one of those large chronic support devices, there was a consideration about how to best treat cardiogenic shock in terms of minimizing morbidity when you go to a long-term support. And these are the two devices that have had the most implantation. This is called the Tandem Heart, which requires a transatrial cannulation to draw blood from the left atrium and essentially have that same circuit we saw before, but can support people for days to probably a week in terms of stabilization. If someone had a cardiac arrest, you could certainly see how much has recovered and make a good decision about long-term strategies. A percutaneous approach that's getting more popular is the Impella Device. It's come in several different sizes. It removes flow blood from the left ventricular apex and replaces it really just above the aortic valve, and has been able to support the circulation in a number of patients for a number of indications. And ECMO, the original circulation that we showed before, has been miniaturized a great deal and is very easy to implant both veno-veno and veno-atrial cannulation to support the circulation, again, for generally days at a time. But I think the final step forward in this paradigm has been the development of partial circulatory support for those people who are not in critical shock but have significant advanced heart failure. And this is the kind of miniaturization where this will be essentially a pacemaker pocket with a pin-light battery size motor that will have a cannula drawing blood from the left atrium and propel it back into the subclavian artery. And this technology has had a CE mark in Europe and is moving into nearness to clinical application in the United States. The final iteration is actually applied through a mini chest incision that wraps the aorta much in the way of counterpulsation, but is able to give partial support to the circulation. So just giving you some summary data. This is a registry that's created in the United States. It's now in Europe called INTERMAX, which is really trying to collate data from all of the implants and all the indications. And I think just giving you a sense of, look at the slope of the increase in the total application of the devices. It's estimated there'll be somewhere in the range of 4,000 LVADs implanted in the year 2014 worldwide. And you can see the majority of them are a single device. The total artificial heart has really not made much of an impression in the field. If you look at this concept that I mentioned before, bridge to candidacy, it's quite a common decision of, is this a patient that will go on to be a good transplant candidate, or should they go to destination therapy long term? And so many of these patients are unclear at the time of implantation. For a while it was the most common. We were really unsure, but it still remains an important consideration for whether they're going to be destination therapy, which has become the more common application of this technology. If you look at the outcomes, it's really quite different, and those that are bridged to transplant are really electively the younger population for sure, have a better outcome than those who are this indeterminate group that it's unclear which way they should go, and then destination therapy, about 10% lower outcomes across the time of follow-up. Age is an important determinant and outcome with these devices. As I said, the bridge to transplant population is also shown here in those who are less than 50, and it breaks down into groups of 10 to 15-year increments. And although I showed you the data in a small series that suggested that they were about as good as those over 70, age does seem to make a difference in outcome. And finally, there are clearly adverse events that occur with these devices, including infection and bleeding, stroke, and device malfunction. This one has basically been taken out of the equation, but early on there is a significant number of comorbidities, particularly around bleeding and a small amount of stroke, but they are blunted over time of follow-up. And the last thing we learned was that doing these procedures now electively. This is a schema of increasing risk from being in shock to being in advanced stage 3 heart failure stable. And they looked at implanting devices in populations that were in this high-risk group versus a much more elective population. And you see that until recently we've been doing largely those people who are in cardiogenic shock. When you look at the overall long-term outcome, those who are in shock or near shock have a much less survival than those who are done electively. And I think that that's where the field is moving into totally elective, well-optimized patients before we implant these devices. But as I said, the devices now have a durability that's in excess of 20 years with a single moving part, so the technology has advanced rather dramatically. I think you can see the miniaturization that's going on in this field, which has allowed us to go into less severe heart failure and patients that really only need partial support. We've certainly developed multiple types of configurations of right ventricular, left, or both, and I think that this hopefully gives you a good sense of how rapidly this field's evolved and how the technology now has allowed it to be expanded rather dramatically. Thank you.